Assalamualaikum and a very good morning to everyone. My name is NURUL Alya Batrisyia binti Muhammad ROFIDI from the class of HS2444A. Today, I will be presenting a critical appraisal of a journal article titled Effect of the Pht517 Plus Injury Prevention Program on Muscle Strength and Landing Biomechanical Markers of ACL Injury During Fatigue Among Youth Soccer Players. For the introduction, in physiotherapy and health sciences, intervention studies play a crucial role in guiding clinical decisions. However, not every study is high quality or relevant to real-world practice. That's why critical appraisal is important. It helps us distinguish between strong and weak evidence and ensure our practice remains safe, effective, and based on reliable data. So, according to Greenhoff and others, critical appraisal enables us to deliver care that is both effective and evidence-based. Kumar et al. Also emphasized that appraisal helps us determine if the evidence is applicable in clinical settings, while Albuquerque stressed the need to go beyond statistical results when deciding if an intervention should be implemented. The objectives of this presentation are: firstly, to apply the Pedro scale in evaluating methodological quality. Second is to assess whether the findings of the studies are clinically applicable. The third one is to determine the reliability and clinical significance of the result of the study. Fourth is to highlight the strength and also the weakness of the study. And last but not least, to develop a critical thinking and appraisal skill that are essential in evidence-based practice. For the article summary, the study aimed to assess whether the Pht517 Plus Injury Prevention Program improved the muscle strength and also the landing biomechanics, which are the risk factors for the ACL injury, especially under fatigue in youth recreational soccer players. So, the design involved 30 male players split into Pht517 Plus group and also the control group. Both groups are trained twice a week for a total of 8 weeks. They were tested before and after a fatigue stimulation using isokinetic strength testing and also the landing area scoring system or LAS. The results shows no significant changes in muscle strength, but there was a significant improvement in landing mechanics in the Pht517 Plus group before and after fatigue. So, while strength didn't improve, the landing control did, which may lower the ACL injury risk. Using the Pedro scale, the study scored 5 out of 10, indicating fair methodological quality. Key items that were not satisfied include no random allocation, no concealed allocation, no blinding of the participant, therapist, or assessor. This weakness increased the risk of selection performance and also the measurement bias. Although the study had a clear reporting and use of valid outcome measure, the lack of randomization and blinding affect its internal validity. Now, let's take a closer look at the methodological flaw identified in the study using the Pedro scale earlier. There are 5 main criteria where the study did not meet the standard. The first one is random allocation. The study used a quasi-experimental design, which means participants were not randomly assigned. This increased the risk of selection bias. The second one is concealed allocation. There was no evidence that the group assigned were concealed during the recruitment. This can affect how the participants are placed in the group and introduce potential bias. The third one is blinding of the participant. The participant knew which group they were in, either Pht517 Plus or the control group. This could influence how they respond to the intervention. Fourth one is blinding of the therapist. The therapists delivering the intervention were not blinded, which may affect how the program was delivered. The last but not least, blinding of the assessor. There was no mention that assessors were blinded when measuring outcome like the LAS score or muscle strength. This could lead to measurement bias. In this slide, I will summarize the attentional strength and also limitation of the study, which help us better understand the reliability and also the clinical relevance of the findings. Starting with the strength, the study had a clear aim, specifically addressing the ACL injury risk during the fatigue, which is a well-documented concern in sport physiotherapy. It used a standardized intervention, this Pht517 Plus program, with a structured and replicable protocol. Validated tools such as a isokinetic machine and also the landing area scoring system were used for measurement, which enhanced the credibility of the outcomes. The fatigue stimulation protocol also gave the study real game relevance, stimulating the condition under which many ACL injury actually occur. And finally, the statistical analysis was well structured, including not just p-value but also effect size and interaction effect, providing deeper insight into the clinical impact. On the other hand, the study has several limitations. First, it used a non-randomized design which increased the risk of selection bias and also weakens the internal validity. There was no blinding of the participant, therapist or assessor. This could lead to performance and measurement bias. The small sample size, which is only 30 participants, limit both the statistical power and the generalizability of the result. The research was conducted in a single setting and only involved recreational male youth player, which meant the result may not apply to elite athlete or females. Lastly, the training frequency was only twice a week, which might be suboptimal for inducing meaningful muscle strength gain. In terms of applicability, several key questions were addressed. Yes, the intervention and control group used realistic field-based warm-up, making the intervention practical. The outcome measure less and isokinetic strength tests are validated and clinically relevant. However, the study used a non-randomized design and purposive sampling from a single school, which limits representativeness and increased bias risk. So while the procedures are feasible for practice, the result may not apply broadly. In this study, all 30 participants were accounted for from the start to finish with no dropout or lessons to follow up. That's clearly shown in the flowchart on the page 178 and it strengthened the reliability of the result. Group assignments were maintained throughout the analysis as shown in both the flowchart and statistical section. This means the original randomization was preserved, which helped minimize bias. However, a key limitation is the lack of blinding. The method section doesn't mention any masking of participant, therapist or assessor that increases the risk potential for bias, especially when outcome could be influenced by the expectation or subjective judgment. On a positive note, both groups received the same warm-up duration and frequency, and their testing and follow-up timelines were consistent. This consistency helped ensure that any observed effects are more likely due to the intervention itself rather than differences in how groups were treated. Overall, the study demonstrated good methodological control in most areas, but the absence of blinding is an important caveat when interpreting the findings. Now, let's critically evaluate the results. Looking at the results section of the study, you can see that the group were well matched at the baseline. Table 1 shows no significant difference in demographic or key outcome, which support the internal validity of the comparison. The outcome measures were both reliable and valid. The study used LES and isokinetic testing, which are well-established tools for assessing SEL injury risk and are supported in the literature. Confidence intervals were only partially reported. They were presented for baseline comparison, but unfortunately not for treatment effect. This limits our ability to fully interpret the precision and clinical significance of the findings. In terms of statistical analysis, the study applied both descriptive and inferential method appropriately. Means and standard deviation were reported and a mix of ANOVA was used to compare groups along with the p-values and effect size. This gives us a good sense of both statistical and practical significance of the result. Finally, when it comes to clinical relevance, the findings are only partially meaningful. The Pht517 program did lead to improvement in LES score, which is important in the context of SEL injury prevention. However, there was no improvement in the strength outcome, which limits the broader impact of the intervention. So, while the study was methodologically sound and showed some promising results, the clinical relevance is somewhat limited depending on the specific outcome. From a clinical perspective, the Pht517 program is valuable for improving movement biomechanics, especially during fatigue, which is a non-risk factor for SEL injuries. However, because it doesn't increase the muscle strength or correct the hamstring quadricep ratios, it should be combined with resistance training. Overall, it's a useful tool in reducing neuromuscular risk factor, but not as a standalone strengthening protocol. In this proposed study design, you have outlined modification to improve internal validity and meet more Pedro criteria, specifically targeting items where the original study fell short. So first, random allocation can be strengthened by using a computer-generated process such as a random number table or software like RedCap to assign participants to groups. This ensures the process is unbiased and also reproducible. For concealed allocation, using sealed opaque envelopes or third-party assignment can help prevent researchers or participants from predicting group allocation before the enrollment, will reduce the selection bias. Next, blinding of participants isn't fully feasible due to the nature of physical intervention.
but partial blinding can be achieved by describing both group as injury prevention warms up. We can help reduce expectation bias. While blinding therapies is typically not possible in exercise-based intervention, we can reduce the bias by separating staff involved in training from those doing outcome assessment. And finally, for blinding of assessor, this entirely feasible. We just need to ensure that those collecting data, whether it's scoring less or operating isocognitive equipment, are not aware of group allocation. Together, these changes aim to increase the methodological rigor of future studies and improve the quality of evidence produced.
These are the references used throughout the appraisal. They include both the original research article and also the key literature on critical appraisal and evidence-based practice. That's all from me. Thank you for listening.